Management session. I would like to invite our speaker, Dr. Piyush, for his talk on nerve block injections. Thank you. I would like to invite Dr. Pradeep from Chennai and Dr. Giri from Chennai to moderate this session.
I'm quite sure I'm audible to everyone. To keep my predecessor company, I'm also not an orthopedic surgeon. So I'll just talk about nerve blocks and go from there. I'm basically an anesthetist who runs the pain management center in Ortho-One. I worked many years behind the screen, that is, doing anesthesia for TKR and things like that. But for the last decade, I've been in front of the screen. I think we will not waste too much time on this. The lower limb, the nerve supply, it's very easy to just remember that it's a femoral nerve, sciatic nerve, and a part of some other nerves near the groin. And these nerves go down like when you put your hand in your pocket, it goes down that way through the adductor canal or the Hunter's canal, which has been used previously for blocks, mainly post-op pain blocks, which I will not touch much. There's a diagram of a Hunter's canal in which you can see the saphenous nerve there, but the problem is that it is surrounded by huge vessels, as you can see, and the chances of injecting the vessel or having blood in your syringe is pretty high. So what happened recently in the blocks? The blocks became more precise, less dose was used, much more motor sparing, which is what we want. We don't want a pain-free patient lying with his left leg or right leg feeling like a log. And small branches could be targeted with the help of ultrasound and fluoroscopy. Thereby, terminal nerves like the genicular nerves came into prominence. The genicular nerves are a confusing bunch of nerves around the knee which supply the synovium mainly without penetrating the capsule. So they are terminal, but it can be, there's a lot of variability and the branch can come from many places. And ultrasound and fluoroscopy is very helpful. And as you can see there, they are, if you make 4 quadrants, the 4 nerves are there, which I'm sure all of you know that. And there is a nerve to the vastus intermedius, which is also important to block. Now, why did this interest in genicular nerve blocks come? Mainly because there was a small group of patients wanted to avoid surgery, were unfit for surgery, which is a very relative term because most people can be taken up for surgery, failed or a rescue block, or a chronic pain secondary to OA, and certain degenerative diseases. Let me give you an example. If you have a 90-year-old patient who has this niggling pain, which he says that is fine, he can live with it, but make my life more comfortable. This is where the genicular nerve blocks come into play. And helpfully for us, the genicular nerve is where the metaphysis meets the main part of the bone, and it is in this curve where it's like a slide, and this also is there like that, and in the inferior thing. In the inferolateral, because of the proximity of the proximity of the nerves around the fibula, we don't want to give a block and give a foot drop. This is the slide which shows where the block should be given. As I said, there will be 3 blocks that should be given. Superior lateral genicular nerve, and helpfully all these nerves are accompanied by the arteries, so that if you do it under ultrasound, this is the way you have to keep the probe, so that you can see on this, the femur will be in the background for the top 2 blocks, and the bottom one, it will be the tibia. This is another diagram which shows where the block should be given. In the previous one, the thing is to put the needle in place and just go to near the artery that you can see there, and avoid the artery. After aspiration, maybe inject around 3 ml of ropivacaine. That's what we do. This is another illustration of how it can be done. That's the probe, and as you can see, it's in line, and it can be, this is the needle coming, and this pink arrow is the artery, which you avoid. There's one more, the terminal branch of the femoral nerve comes as a saphenous nerve and supplies the inferomedial area. There are a lot of people who have remnant pain in this particular area, just lateral to the tuberosity. In fact, we have done some work in our hospital about a block in this area. So what you have to keep in mind is why these people, even a single shot block can last for long. Because the nerves are the saltatory condition, saltatory transmission, the nerve is action potential and all that, it goes down very fast if it is a myelinated nerve. But once it's not myelinated, it's very slow. And it is seen now that in elderly patients, the nerve study, lot of nerve studies show that the conduction down the nerve slows down with age. Sort of, as everything else slows down, this also slows down. So that's why sometimes you give a block. Basically, it's given as a diagnostic tool, but it can be given, and you'll find that this fellow doesn't come back for 3 or 4 months because he had good relief. So that's about this talk. This is the only one thing I wanted to show. Although it looks very simple, but a heavily muscled person, sometimes it's like searching for a needle in a haystack. Thank you.
Thank you, sir, for the nice talk. So, as we are running short of time, we'll have the questions at the later, after all the 3 talks. So, next I would like to call upon Dr. Deepa Shri to talk about genicular artery embolization.
Good evening, everybody. I would like to thank the organizers and Dr. Santosh as well for having me over here. I presume there are no cardiologists over here. We are always considered the odd ones out, or the cross-specialty stuff is always there when it comes to interventional radiology. But my concept is everything can be sorted over a drink, and I think this is how we should be when it comes to IR and any other specialty. So I'm here to talk about genicular artery embolization. I work at Rela Hospital, Chennai. I work in the IR department. So today the outline is we are going to understand a little bit about the anatomy, know what to do, know what not to do, know a little bit of the data, and also know our patient. So first I'll take you through the data or the evidence so we all know what's happening. I mean, I don't have to go through this. I think all the talks have been so brilliant. We all know what's happening there. The whole point of genicular artery embolization is to cut down the angiogenesis, which happens in anybody with a mechanical damage or even in recurrent hemarthrosis. The concept of genicular artery embolization came in, the initial studies were on hemarthrosis. Later on, it was extended to osteoarthritis, as we all know, and that is because of the neoangiogenesis, and which causes inflammation, cartilage destruction, and sensory nerve growth. So initial studies were on animal models, but later on there were RCTs. One of the first RCTs was on GAE versus placebo. It was a single-blinded study, 21 patients with mild to moderate knee OA. They were randomized to GAE and sham procedure, and the one-year follow-up showed a significant improvement in VAS and WOMAC score. And again, there was an RCT2 on slightly, more number of patients, and 59 patients. And again, this is for KL2. There was an improvement in, the 41.3% in KOOS versus 29.4%, and 76% complete embolization versus 37% incomplete. I'll tell you what is complete embolization and incomplete embolization in the next set of slides. But this was a second RCT. And then there was an RCT on, there was a systematic review comparing intra-articular injections versus radiofrequency ablation versus GAE. And again, in this, it was shown that radiofrequency ablation and GAE were found to have most profound treatment effect compared to intra-articular injections. So there was a meta-analysis of 11 GAE studies on 225 patients, and even on this, you can see an improvement in VAS and WOMAC score, and you can see an improvement lasting up to 24 months, up to 2 years. And that was the, think about the GAE compared to the intra-articular injections. Again, this was a meta-analysis on 9 GAE studies, and pretty much shows the same thing. There has been improvement in the VAS score and WOMAC score as well in these patients. And again, this was a Genesis study looking at the genicular artery embolization using permanent microspheres. This is what we use as the embolic agent. And again, you can see there's an improved quality of life and ADL as well at 12 months. So in severe OA, do we take up patients with severe osteoarthritis? What are results? Again, it's a little bit of a contradictory results. Kim et al., they said the long-term durability is probably questionable, but there was no difference in the outcomes in severe versus mild according to this particular paper, the second paper, which was published in 2021. So what do we see when we do GAE? In terms of the adverse effects or in terms of the side effects, bone infarcts that people talk about, because when patients come to us, when we say we are going to block the blood supply, the first thing is what is going to happen to my bone? If you're going to block off the blood supply, are we going to have bone infarcts? What is the consequence of genicular artery embolization? But the bone infarcts are very, very, very minimal. I'll tell you why people don't get bone infarcts. Contrary to what everybody thinks in GAE, we don't actually block the blood supply, because embolization word actually means blocking the blood supply anywhere is called embolization. But here we are not blocking the blood supply. What we are doing is we are normalizing the supply. We are taking away the extra synovial blush, the synovial vascularity that somebody has. We are just going to cut down that, but we're not going to block off the entire blood supply. So the whole, they're not going to have bone infarcts because we're not going to block the blood supply anyway. It's not complete embolization there. Moving on, whether we do, when patients come to us, do we do MRI? Yes, we do MRI only to exclude the other causes, but otherwise an X-ray should suffice. And again, there is one paper, patients keep asking us, okay, how many times do I need to undergo this procedure? Is it just a one-off procedure? Do we need to come back again and again? Because it's so important for people to understand when they spend so much money that they don't have to invest again. GE, can that be repeated? Yes, it can be repeated. Usually it lasts for about 24 months, the pain relief, according to several papers. Obviously, it's not comparable to TKR, but then the repeat GAE was seen in, at least, I think, in this particular study, up to 8.4% of patients had a repeat GAE. So in terms of the anatomy, I don't have to go through the details of the anatomy. I mean, you all are very well versed with the anatomy. But in this, how many arteries do we tackle is something that I'm just going to very quickly go through. What we are actually supposed to do is, this is a blush that we talk about, how we get into the arteries, which route do we get into the arteries. I'll show in the next set of slides. But this is a blush that I'm talking about. This is the angiogenesis. This is a vascularity that we are targeting in genicular artery embolization. So moving on, so these are all the vessels. So pretty much it's usually the descending genicular artery which is usually targeted, and this is the culprit vessel in majority of the patients. We also target the supralateral, supromedial, infralateral, inframedial, and ATRA at times, anterior tibial recurrent, but the median geniculate artery and the superior patellar artery, they are not targeted because of the predominant patellar supply. We don't target those, but those are all the vessels which are targeted in genicular artery embolization. There are several variations. I wouldn't go into the details of this. Superior patellar arteries, again, something that we carefully look for and we spare. So the number of side effects or the complications depends on which vessel we go in. If you just get into superior patellar artery, or if you just go into median genicular artery and embolize, patients are going to have some problems. But then we need to be mindful about which artery to target and not overcook it or overdo it, because all that we are targeting is just cut down on the blush. So this is how the descending genicular artery comes. It is a V-shaped structure that we see on the angiogram. And when you see that, the outer branch is the cutaneous and the muscular supply, so we don't target that, but the innermost branch, the medial branch, is what we target. So that is DGA. Then we have the supromedial genicular artery. These are all these vessels have got a typical shape to it that we can identify on the angiogram. Then we have got this inframedial genicular artery, which is the J shape, the reverse J shape. So we look at these vessels and target all these vessels. And ATRA as well. So there are several variations. I wouldn't go into the details. And this is the approach wherein you're seeing a catheter coming from the pedal artery. So this usually we target the PTA or the 80th or the dorsalis pedis. So usually it's a posterior tibial artery that we target. Patients can go home the same day. They don't have to lie flat, unlike femoral puncture, wherein you have to lie flat for 4 hours. They don't have to do that. So usually we do the pedal puncture and get inside, and that is the approach for genicular artery. Usually there are a lot of collaterals. So even if you target one artery, even if we get into the descending genicular artery, usually they collateralize with the other branches, and the job is done just by getting into one artery itself. So in terms of the patient selection, very quickly, we know that anybody who's not suitable for surgery, obese, elderly patients with cardiac risk factors, or COPD, or those who do not want major surgery, Jehovah's Witnesses in other countries especially, and for those who are looking for temporary relief. When I say temporary relief, something like 2 to 3 years is something that we can provide. So this is a pathway that we follow, and in terms of the indications, OA, again, moderate to severe knee pain and failed initial conservative therapy, contraindication to knee replacement. Those who prefer to avoid or not ready for that, hemarthrosis following TK is also one of the indications. Synovial hypertrophy and hypovascularity on MRI is also one of the indications. Contraindications, these are all the different contraindications. GAE, never as a first line or initial line therapy. This is always as a second line. And initial clinic visit, this is the workup that we do, looking at all the scores, and these are so important to tell the patients. Can I take 1 minute more? Yeah, thank you. So the procedure, it's again very simple. Patients can walk in on the day of the procedure. They can walk in the morning and they can go back home the same day. If it's a pedal puncture, no bed rest is required. So sometimes we do the Doppler as well, just to ensure that there isn't any other cause of the pain. If there is a claudication pain, we can tackle both the things. We can just get in and do the angioplasty of the vessel, like an SFA or a popliteal, and we can also tackle this as well. So these are all the different catheters and equipment. I wouldn't go. This is the reason why this is expensive, because all these catheters and wires are so expensive, as you all know, in IR. The technique is a pedal axis, done usually under local anesthesia. Sedation is not required, and so all that we require is a cath lab and these different catheters and the wires. And ice packs. One important thing that we do is, because they have these lot of cutaneous branches, there were a lot of reported cases of skin necrosis in the initial cases. That's only because of the cutaneous supply. But otherwise, it's a pretty straightforward procedure. The embolic material that we use is the PVA particles or the embospheres. Of late, people at the research level, they're also using the intra-articular mesenchymal stem cells, which is coming up in a big way, but that is for another day. But that's about it really in terms of the GAE. So this is one of the complications that you can encounter if you're not careful with the supply. There is a need for further data, and these are all the different RCTs which are ongoing at the moment. But yeah, looking forward to more. So in conclusion, it's a very safe and effective procedure. Knowledge of the anatomy, what we are doing is very important here, and more data is needed to understand the long-term efficacy. More than 2 years, we don't have data as of now. Thank you so much.
Thank you, Dr. Deepa, for the wonderful talk. Next, we call upon Dr. Karthik Babu Natarajan for radiofrequency ablation.
Thank you. So my second talk is on genicular nerve RF ablation. Now, we do know as doctors, we are not able to reverse osteoarthritis, right? So we've been trying everything, supplements, exercises, weight loss, PRPs, BMAC and stuff. So one of those techniques is we try to denervate the joint, right? So basically, try to cut off the sensory supply of the knee joint. So that is the genicular nerve RF ablation. So just like I talked in the previous lecture, so we have about 4 categories of pain interventions: the cortisones, the HAs, the regenerative products, and then you have genicular nerve radiofrequency ablation, which is basically a denervation of the joint. So conservative treatment is obviously tried. So basically your role for genicular nerve RF ablation is grade 2 and grade 3 OA. It can be tried in grade 4 OA if the patient is unwilling or unfit for surgery. Occasionally, we do get some patients who have had the knee replacement and who come back with pain for a genicular nerve RF ablation. Right? So the nerve supply itself, we do know majority of the genicular nerves are coming in from the femoral and from the sciatic. There may be an odd branch from the obturator and from the lateral cutaneous nerve of thigh. So since majority of these patients have anterior knee pain, we try to target the anterior nerve supply. So majority of the supply is coming in from articular branches from the femoral nerve. So if you take radiofrequency ablation itself, there are several kinds. So you have one which is the conventional. So normally when you say radiofrequency ablation, it's the conventional radiofrequency ablation. So what we do is we put a needle with an insulated part and an active tip. So the job of the physician is to keep the active tip beside the nerve. So once we place this under ultrasound or fluoroscopic guidance, we can do a sensory and motor stimulation to know that we are beside the nerve. And then once the location is confirmed, give local anesthesia and then do a thermal ablation. So when I say thermal ablation, the ablation is done somewhere at around 70-80 degrees centigrade for a duration of 90 seconds. So standard thermal ablation is done at 80 degrees for 90 seconds. You have an option of doing it in 2 or 3 places to block these nerves. The other option is to do something which is called a cool radiofrequency ablation, and there is one called cryoablation. The cool radiofrequency ablation is one where you create a bigger lesion. So since you create a bigger lesion, the duration of analgesia is a little longer. There is also one where you freeze the nerve, which is called cryoablation. Right? So these are the conventional radiofrequency machines that we use in our pain clinics. So essentially, we started doing RF ablations in lumbar facets, sacroiliac joints, and then we started doing joint denervation. So currently, we do a lot of genicular nerve, knee. We also do the branches from the obturator for the hip joint. There is also a way to denervate the shoulder joint. So when I say denervate, it is not complete denervation. So if you see the nerve supply for the knee joint, we are looking at something around 10 to 11 articular branches. So at best, when we do the RF ablation, we'll be able to block, let's say, 7 of them. So it's not a complete denervation. So a lot of times when I talk about genicular nerve RF ablation, somebody puts up the hand and says, will it become a neuropathic or a Charcot's joint? It doesn't, because we don't completely denervate the joint, right? So you have one where you can do a single lesion. So this is a normal RF machine. You can also do multiple lesions at the same time. So you have multipolar, multi-electrode RF machines. This one is a cooled RF machine here. Now, the thing with the cooled RF is normally when you create a lesion, there is a bit of charring. So usually the lesion, if you put a needle, is about 4 millimeters on either side. In the cold RF, because there is cooling, so saline is irrigated into the system, the charring doesn't take place, so it creates a little bigger lesion. So generally, if you create a bigger lesion around the nerve, it takes more time to regenerate. If it takes more time to regenerate, the patients enjoy longer duration of analgesia. And this one here is the cryoablation here. Right. So for the knee joint, so mainly we are going to target articular branches. So it's very easy to block the femoral at the level of the hip, but if you block the femoral at the level of the hip, obviously the muscular branches that go to the quadriceps muscles will get blocked. So we try to block it as distally as possible. So innervation of the knee joint, so you can see all these nerves. So madam talked about suprolateral artery. So the suprolateral artery, genicular artery, is accompanying the suprolateral genicular nerve. Then you have the supromedial and then the infromedial. So your main targets are suprolateral, supromedial and infromedial. So the saphenous nerve comes down and then the infrapatellar branches wind up and go back into the medial knee. Now, we do know that majority of patients have medial joint pain. So always concentrate on doing the supromedial and infromedial aspect of the knee joint, right? And most of the time, we don't break our head about the posterior branch, which supplies from the sciatic. So mainly we concentrate on branches from the femoral. So if you're going to put 3 needles, one is supromedial, one is supralateral, one is infromedial. So this can be done under fluoroscope or ultrasound guidance. So if you're using ultrasound guidance, search for the artery. So you're going to see a pulsation. The nerve is beside the artery, right? So cadaveric studies show these are the various nerves that come in, and these are the nerves that you should target. Since we are targeting it almost very distally, there are no muscular branches, so there is no real risk of anything else going wrong here. So these are the targets that you're going to use for a genicular nerve RF ablation. So you're going to put 3 needles, which are radiofrequency needles, on 3 aspects above and below the knee joint, right? So roughly this is what we are looking at. So this is supromedial. So your junction is basically the junction between the shaft and the condyle here. This one is supralateral and this one is infromedial. So you'll be doing it in multiple places. So in the lateral view, you're going to be somewhere along the mid shaft of the femur. So this is me doing a genicular nerve RF ablation. So the patient's head end is here. This is the left knee. I'm doing this under fluoroscope guidance. So I've put 3 cooled radiofrequency needles. So the patella is here. This is supromedial. This is supralateral. This is infromedial. So this is done under good sedation and local anesthesia. And then once you go inside, you're going to do a stimulation to know that the patient is having some paresthesia inside the joint. And this one here is the RF ablation. So you can see inside the RF needle, there are 2 types of wire. The black wire is the electrical component of it. The transparent one is the saline that's being irrigated. So this is cooled radiofrequency of the genicular nerve. So this procedure, the fluoroscope image is more or less like this. So this is medial, this is lateral. So this is supromedial, supralateral, and infromedial. So this is the lateral view here, right? So the denervation can be done successfully. The truth of the matter is this procedure came with a lot of promise about 4 or 5 years ago, but somewhere along the line, the charm of it went away because we were getting results in about 60-70% of the patients. And somewhere along the line, the focus shifted more towards regenerative and other type of stuff. So genicular artery, genicular nerve RF ablation is something that we do routinely. But to tell you the truth, the indications have sort of reduced now compared to the interest that was there earlier. Now the focus is more on PRP, BMAC, and SVF. So if you want to do this, so this is the cooled RF system that I'm using here. So this is the RF itself. This is the saline irrigation that's done. So at this point of time, mainly the indications for genicular nerve. So this is ultrasound-guided genicular nerve RF ablation. So at this point of time, mainly the indications for genicular nerve RF ablation are patients who are grade 3, high grade 3, grade 4s, unwilling, unfit for surgery. So that is one category. Post TKR, sometimes we can find these nerves and then burn them to denervate the joint. That is another category. there is also an option to do a genicular nerve denervation along with an intra-articular HA or an intra-articular PRP or an intra-articular BMAX. So sometimes physicians like to combine both these procedures. So you have an option of doing the denervation along with the intra-articular injection as well. So in terms of procedure itself, for the RF ablation, you can use fluoroscope or ultrasound guidance. This procedure can also be done in post-TKR situations, right? So this is some positive evidence coming up for cooled radiofrequency ablation for knee osteoarthritis. So in whatever experience we have with this, these patients do better for about 1.5 to 2 years. So somewhere around 12 to 18 months is what you can expect. So after some time, these nerves will regenerate. If it regenerates, you have an option of repeating this procedure. So thank you very much. That's my take on genicular nerve. Thank you.
Thank you, sir, for your detailed talk on your denervation of the genicular nerve. So now I would like to call upon all the speakers onto the dais, and we'll take the questions from the audience. No questions?
Hello. The following injection, especially blocking the nerve, over the period of time, the joint is becoming like a chalk-coats type of joint. Completely no pain, but the deformity is progressing very rapidly. The patient, they do present with progressive deformity with disability, but there is no pain. But those patients, how do you deal in these situations?
I did mention this in my talk that when you do block the genicular nerve, there are about 11 genicular nerves, and at best, we will be able to block 7 of them. So we will not be able to block or completely denervate the joint. So we do find that after the genicular nerve, the joint sense proprioception are not gone fully. So in my experience, I have not seen neuropathic joints or Charcot's joint after genicular nerve RF ablation.
Thank you.
Sir, I have a question to Dr. Piyush. Sir, can we use, blindly can we give the injection into the supracondylar region on both on the medial and the lateral side without using the ultrasound? Will we still be able to hit, and how frequently you use the ultrasound?
Ultrasound, now it is, everyone uses. But as my hair testifies, I started without ultrasound. So you can use it, and if you are very careful, you can avoid the vessel. If you avoid the vessel and you are just near it, and on aspiration there's nothing, then you inject very slowly. That's what I tell all my PGs, that inject very slowly, take around 5 minutes to inject slowly. But now it is, I think you have to have an ultrasound.
Yeah. And how much is the longevity, sir, without pain? I mean, the patient is...
See, that's I mentioned it. I've seen that in the old patient will have something what Yuvraj said, inferior-medial region, he will have pain. So you give a block there, planning for some other procedure, but very often they said, I'm fine like this. So there is a, I don't know how you talk to them, how active they are, or perhaps they are happy with the life they are leading. So that also, and I've seen for 4 months, 5 months.
Thank you, sir. And a question to Dr. Deepashri. Madam, if, what would be the status of your, the grading of your knee that you deal with? Like what would be the grade 2, grade 3?
Grade 2.
Grade
Usually
2,
it's grade 2.
That's it?
Yeah.
Okay.
Yeah.
So with the deformities and all, what is your experience with the deformed knees, like with the varus or a valgus, and a little higher than grade 2? You don't take in at all?
I haven't really, so far I haven't taken it. Even the evidence says that the results are good only for grade 2, but for severe OA with deformity, it is not proven to be effective as of now. Yeah, just waiting for more data on that.
So basically it works by reducing the synovitis.
That's right, yeah.
Right. Thank you.
Thank you.
Yeah, so one question to the panelists, sir. Which works better, the embolization or the nerve block? Or what is the guideline on that? And how expensive is the treatment? Because these are new things which are in the pipeline. So which works better? See, I know the block is very cheap, but probably the longevity is, very short. So that's where, embolization and nerve ablation comes. So what's the take on that, sir?
It's a difficult question. But yeah, I see in terms of embolization, as they rightly said, it is slightly more invasive than the nerve block. But then the results show that, or the evidence at least says that it is effective for at least up to 2 years and sometimes even up to 3 years. I mean, that is the only evidence. And the other take on embolization would be, some of these patients, elderly patients, they would want an angiogram and they would have some kind of a pain because of other reasons, the claudication pain. So when they have that, both the things can be tackled at the same time. But other than that, in terms of the evidence, I really don't know, because this is considered to be effective for up to 3 years. Whereas you said your data, it's about 12 to 18 months is what the nerve ablation is talking about. Probably slightly, in terms of the longevity of in terms of requiring the recurrent procedure or the second procedure, this probably lasts a little longer. That's my take on that.
Yeah, the nerve ablation is probably cheaper, safer, and probably slightly shorter is what the data says. Shorter in terms of efficacy. So obviously, if you're looking at cost, the nerve ablation is probably, let's say, 30 to 40,000. The embolism is in six figures.
No, well, it costs about $1 lakh. So
Yeah,
it's about 1 lakh. But then we have been doing it only on insurance patients so far, people who are capable of that. But I have been combining. It's not a study, but then planning to do that. But I've been combining the embolization with PRP. So if they have embolization, they get PRP free. So so that's something that we've been doing just to complement what we're already doing. Yeah.
And taking away patients from us.
Which is working is difficult to say. Yeah, exactly. This is a thing. Yeah.
I'll just ask a question to embolization. As an orthopedic surgeon, one is, how do you go about telling an orthopedic surgeon which is the exact indication that they should be referring patients? How are the patients reaching you exactly? Because most of these patients who have OA knee would be going to an orthopedic surgeon first, right? So that means there has to be a reference. So what is the exact indication where an orthopedic surgeon says, okay, now I cannot do anything. I will not even inject anything. I can't even go in for osteobiologicals. And only arterial embolization is going to help you. Can you give me one such exact indication?
Mike.
I mean, as I said, the only we are not a first line. I mean, it's definitely as a second line. So if an orthopedic surgeon, if he feels that somebody is not suitable for a knee replacement, it could be any comorbidity, obesity, it could be anything, renal failure, whatever. So if they feel they're not suitable, that is when we take it up. We're never going to say that, this is an alternative to knee replacement. Definitely this is a second line therapy. And the kind of referrals that we have been getting is, we have a referral base wherein, they are, it's like an outside agency wherein they just do a lot of digital marketing, and then they just kind of, get patients through digital marketing. And most of the patients, they are triaged by this referral group. They are triaged to whether it is a mild. We actually educated them on what is mild OA to severe OA. And most of these mild OA cases are sent to me directly from the referral base, but never from an orthopedic surgeon so far. Yeah.
Management. Don't you think this is sort of a conflict of interest coming in terms of the customers or patients who have OA knee getting confused? Okay, So apart from orthopedic surgeons, we do have someone who's doing something different than what orthopedic surgeons are doing. So
Yeah,
if you have marketing agencies.
Sir, I'll add to your question. I'll rephrase your question as well, sir. What if, madam, there is a patient with a root tear, okay, a meniscus root tear. He's got a grade 2 or grade 3 OA knee, and he comes to you now. He has not consulted an orthopedic surgeon. Okay, he comes to you straight away with a root tear, where you haven't done a MRI, or you haven't clinically examined the patient, you haven't found out if the patient has got a root tear or not. And then now, how much will your injection work and how much your intervention work? And how much can the pain be relieved in case of a meniscus lesions?
I'll try to rephrase that in another way, as a positive way. If there is a synovitis, or if there is a velonodular synovitis, is there an indication for embolization? So we are looking at it as negative. I'm looking at it as positive way, where these are another reason for knee pain. So let's look at it as knee pain. Grade 2 OA. There are a lot of other causes for the pain. OA, osteoarthritis is not the only cause. There might be synovitis, there might be root tears, there might be so many other things. So suppose if it's having a velonodular synovitis, is there a role for genicular embolization?
I mean, if
Mike.
the evidence doesn't speak about the role of GAE in synovitis, but then I invariably so far have been doing MRI on every single patient who's been referred to me with a knee pain. This is only to exclude that there aren't other causes that we are missing. I mean, even recently we had a patient who had a little bit of, it's not just the clear-cut OA, but then he had I think he had an ACL tear quite a while ago, and ever since, he never had any recovery from that. Those are the cases that I would never take up, and usually we send them back to orthopedics. But then, it's usually MRI which gives...
As an orthopedic surgeon, it's very difficult for us to get convinced for an OA patient to be sent for this, but there are other indications. It's more logical if a genicular artery embolization is there to maybe debulk or reduce the synovitis so that we can go on later on, or the recurrence rate for velonodular synovitis might be less. So probably as a team, as an orthopedic surgeons, we must be aware of what's happening in our allied world, not to ignore them, but at the same time, that's the whole reason for this meeting. So let them explore the indications and come out with evidences, and we'll wait for more evidence before we...
The idea is the youngsters should have to know what indications and where we have to, we have all these kind of modalities available where, the specifications and how, where to involve them, because we have to work as a team. So it's very important for the youngsters to know as well. So that's
this is for creating awareness, and what more research and evidence have to come to a consensus. Thank you all. We'll go on with the next session as we are running late.
Thank you, sir.
Thank you very much.